Good morning, everyone. I am so happy to be here with you today. I see some familiar faces, and it's a lot of fun for me to be able to talk with you and to discuss the cardiac issues related to Duchenne muscular dystrophy outside of a patient encounter. You know, there's so much going on at those times with each of our appointments, so I really want to use today to sort of give an overview of what do we need to think about regarding lifelong care of the heart for people with Duchenne muscular dystrophy. And please stop me at any time with questions, and really I do want this to be informal. Before I start, I just want to see in the audience how many families have been to a cardiologist for affected people in the past year? Okay, great. And in the past 3 years? Okay. All right, good. So most of this should just be reviewed to all of you, but let's go. So how does Duchenne muscular dystrophy affect the heart? Well, of course, the key thing we're worried about is muscle weakness. But importantly, all muscle is not the same. We have 3 different types of muscle in the body. And the cardiac muscle is actually different than the skeletal muscle. So while it's affected by dystrophin abnormalities, it's not exactly in the same way as skeletal muscle. If we look, zoom in close here at the cardiac muscle cells, this next image here shows all the different components of the heart muscle cells and all the tissue that connects them together in order for the heart to contract effectively. And if we look here, this very big structure here, that's dystrophin. And so when you have abnormalities in dystrophin, it interferes with the way that all of the muscle cells contract, but to various degrees. And when that's happening, it affects the heart in different ways. We call it cardiac remodeling. And what that is the changes on the neurohormonal level, the structural level, the changes that happen in the heart muscle related to having any sort of abnormality in the heart muscle structure. And we refer to cardiomyopathy just meaning any abnormality of the heart muscle. So whether you've had an infection in your heart, whether you're born with a dystrophin abnormality, whether you've had sort of a heart attack or have coronary artery issues with the heart, any injury to the heart muscle is called a cardiomyopathy. It's a very general term. But Duchenne muscular dystrophy falls into that category because there's an abnormality in the heart muscle that produces an effect. And that effect is really a gradient over time. It's really a progression, and everybody is different. So the earliest effects that we can see, if we look on the left side of our screen there, it's just abnormalities in the EKG, a little bit of conduction abnormalities, nothing with any clinical significance. But if you looked at the electrocardiogram of someone with DMD and someone didn't know that they had, they'd be like, you know, why is this, the electrical activity, the pathways of the electrical activity is a little bit abnormal. We have what we call diastolic dysfunction, which as the heart muscle cells change, the heart becomes a bit stiff. We call it a process of fibrosis. That, imagine if you cut your skin or you have an injury in your body and the way that the skin heals with a scar. And that scar tissue, it's not exactly the same as the skin which has not been injured. I think that's a very good model to think of this in. So the same way, if the heart muscle, if your skeletal muscle has an injury to it, meaning a dystrophin abnormality, well then the way that that muscle heals and the way that that muscle affected is a form of scar tissue. It's a form of injury that heals, and that healing changes over time. And everything we do is to try to get that heart to be healthy and those muscles to work as well as possible. But it does produce this fibrosis, this scar tissue effect if you were to look under a microscope at the heart. And when you have that, that causes what we call diastolic dysfunction, where the heart can be a bit stiff. We can see some of those changes sometimes with fibrosis, say on cardiac MRI, just sort of says that it's there. And then at later stages of disease, we see that, well, it's not only the heart muscle cells that are getting affected, but the cells as a whole, the muscle tissue, the chambers start to dilate and they can get weakened, and that's called systolic dysfunction. And then if your heart muscle is weak and it can't deliver all of the circulation that your body needs, that results in a clinical syndrome called end-stage heart failure. And we're going to talk about all these different stages, but this is just sort of the concept that it's a progression. So key point is just because you have a dystrophin genetic abnormality, genotype, cardiomyopathy, and heart failure are not the same thing, right? And that's a very important thing, to grasp. The dystrophin gene, as we said, that's the stimulus, that's the absence of dystrophin. Cardiomyopathy is how the heart muscle is affected by it, abnormality of the heart muscle and function. And heart failure is a whole clinical syndrome where the heart is unable to keep up with the body's metabolic demands. And that's really important because these are different targets for intervention, right? We hope, and with these new drugs coming out, to develop medications that can interfere here, where we can mitigate the effects of the dystrophin changes, of the abnormalities in dystrophin. That is our goal, I think, with regard to DMD, and there's progress being made on this goal. But I have that arrow fuzzy, that's not your eyesight, because we're not quite there yet. But what we do have, and what with the key focus with lifelong heart care in this setting of DMD, is focusing at this part here, that how do we try to prevent the cardiomyopathy, the abnormality of the heart muscle, from causing heart failure? Okay, you can live with cardiomyopathy. You want to prevent heart failure. Okay, questions with that point right there, just to stop everything. Okay. So, what are signs and symptoms of cardiomyopathy? Well, the key thing is commonly that there's none, right? That's why we have screening regimens, because you can be feeling fine and not have any symptoms and doing what you do, and the heart muscle could be a bit weak. The heart muscle could be a bit stiff, could have some diastolic dysfunction. Your EKG could be a bit abnormal, but everything can be working fine and you don't have any symptoms from it. Okay, what are some of the early symptoms? Sometimes just a faster heart rate compared to other people your age. Sometimes may have some extra beats, some palpitations in the heart. And if your heart is developing systolic dysfunction or more severe degrees of dysfunction, you could get more symptoms with exercise. And with that, I would say with exertion. So anything that is exertional may develop more increased work of breathing and other symptoms associated with that. So because the symptoms could be so subtle, and most commonly in all of the early and even the medium stages, I would say the middle stages of cardiomyopathy, that it's really asymptomatic, screening is very important. Because you don't want to wait until you're feeling sick and you have symptoms of heart failure before you start treatment, before you start trying to intervene and to modify those effects. So at this point in time, really, echocardiogram is the mainstay of therapy, probably at all the centers in the nation. And we typically recommend that starting really from time of diagnosis or so, to be screened from every 2 to 3 years until age 9. And then we recommend annual screening once a year, because it's during these teenage years that the body seems to change more, right? And during those years, you want to have increased surveillance for any changes that we're seeing as targets of intervention. The reason why I bring up that screening even at time of diagnosis is important, not because I'm worried that you're going to have cardiomyopathy at such a young age, not at all, but that is the time to start learning about it, to recognize that, hey, cardiology is part of your care team, right? To start asking questions. What can we do to modify it? To sort of get used to, your child having imaging studies, when coming to the doctors, to have baseline studies. So it's really opportunities for learning at the earliest ages, as well as making sure that we'll have the earliest ability to detect any abnormalities. More and more, we're using cardiac MRI, which is a bit more sensitive imaging. You got a lot better details of the heart muscle. You need to use an IV and different contrast materials if you want to detect fibrosis in the heart. So that's why we sometimes don't use it as routinely as echocardiogram. It takes a bit longer, but it's something that we're using more and more for making sure that we detect and know everything about the heart muscle size and function, as well as looking for new targets of potential intervention. Okay. We have other forms of imaging, nuclear imaging, MUGA scans some centers use, and then just basic electrocardiograms and Holter monitors looking for any arrhythmias that perhaps aren't being detected. Right? Does this sound familiar? This would sort of be routine sort of cardiac screening that most of you in the room, sounds like you're already involved with. So again, our goal is to really prevent and delay the progression of cardiomyopathy. And we do have medications that can decrease these harmful changes in the heart over time. This process called cardiac remodeling. And these are the same medications that are used in children and in adults who have cardiomyopathy from various different reasons. Because what we're doing, we're targeting the body's response to having a weakened heart. We can't control the injury yet, but we can control how the body responds to it. And that's where these therapies come from. Angiotensin converting enzyme inhibitors, ACE inhibitors, enalapril, lisinopril, perindopril. These are common names of these drugs. Aldosterone blockers called aldactone, spironolactone. Beta-adrenergic blockers, carvedilol is the most common beta blocker. And these medications are used together, I call it the happy heart cocktail, right, to try to really target the heart and support the heart from different mechanisms to, again, try to mitigate the effects of having the genetic change. It's also really important to treat modifiers of the disease, non-cardiac issues. Respiratory support is key to a healthy heart. Obstructive sleep apnea is a lot of strain on the right side of your heart. Again, that's something that can be modified. So regular pulmonary screening, pulmonary support when it's needed is the best intervention you can do for your heart to help keeping your heart strong. Avoiding extra work that your heart has to do, avoiding hypertension. Sometimes some of the younger kids, if they're on high-dose steroids, that side effect of that at times could be hypertension. Very important to manage. Hypertension is like your heart's lifting weights. And so actually maintaining the lowest blood pressure that you feel good with is the healthiest state for your heart to be. And also weight management. Both ends, avoiding obesity, which is sometimes difficult. In later years, it's harder to exercise, it's harder to burn calories and everything. So very, very tight vigilance over calories that's taking in. Maintaining good nutrition is really key. Because while obesity isn't healthy, neither is malnutrition, right? That, the heart needs fuel to work. And so really, I'd say with respiratory support, nutritional support is really key modifiers of cardiac disease. Questions at this point? Let me stop here. Nope. Okay. And then another factor is to prevent heart failure in situations where there's increased risk of heart failure. So for instance, if you have a big scoliosis repair surgery plan, which is not too uncommon to have spinal rods placed, that's quite a big procedure from an orthopedic standpoint, right? It's long anesthesia. There's a lot of bleeding, there's a lot of management that can provoke heart failure. And so being aware of making sure that you have a cardiac checkup prior to going for any big surgical procedures is a great way to prevent problems, right? Common problems, that can be managed in the ICU, that can be managed proactively to avoid heart failure from developing. And we work very closely with the teams here, at Packard, with talking with our cardiac anesthesia teams and with our ICUs for postoperative management, controlling fluids, and just at least being aware that, hey, if recovery isn't going as expected, to at least think about the heart. Does the heart need help here? So a lot of it is just being proactive, right? So what is heart failure? Heart failure is when there's inadequate blood flow to meet the body's needs. And the body compensates by that fight or flight response, right? So your heart rate increases. Your blood vessels in your arms and legs constrict. That raises your blood pressure, right? It diverts blood away from your intestinal organs. Your body holds on to water and salt, right? And this is all a naturally programmed survival response that we all have. And these, while initially it can be beneficial, these symptoms then can perpetuate symptoms related to heart failure. Your body's holding on to water, and if your heart isn't pumping that effectively, you can start getting swelling. You could get fluid in your lungs, right? We spoke about how hypertension is bad for the heart, right? We want to make the heart to have as easy a job as possible to work. Well, if you have all this adrenaline that's circulating in your body saying for your heart rate to go faster and your blood pressure to go higher, those aren't beneficial responses. And that's where our medications of beta blockers come in to try to dull down that response. Our ACE inhibitors, that's where that comes in, trying to keep the blood vessels open, trying to reduce, trying to affect the cellular changes in the heart. That's where we use diuretics to try to keep the body in the more dry state. And these medications and interventions together can really manage and prevent heart failure, right? Because as I said, our target are these cellular changes. And that's what, in addition to sort of the general effects of lowering heart rate, lowering blood pressure, we're also trying to target these cellular changes. And that's why these particular medications and new heart failure medications that are coming down the line, they're being used more and more with ischemic heart disease, that we'll have more tools to be using in our population here. So again, the key thing is education, because the early signs of heart failure can really go unrecognized for a long time, particularly because many of the classic signs are associated with exercise. And since most often cardiomyopathy and severe cardiomyopathy is with older age in boys with Duchenne muscular dystrophy, it is true that often that you're wheelchair bound before you start having any significant problems with your heart. And so exercise is it's a much more subjective measure. And that's why actually you can go without symptoms, if you're not having your heart screened, of having pretty severe heart dysfunction without knowing it. Because a lot of your body doesn't have that much work to do if you're not trying to keep up with your friends running and all that. Now, there is a lot of exercise, that I know our boys do and everything, with physical therapy, with occupational therapy, with transfers, with wheelchair-based sports. There is a lot of exercise. That's why I always talk about, and really important, what is exercise for your child? What is exertion for your child? And to try to kind of, be mindful of that, and then notice, well, how do you feel when you're doing that? So when you're doing your transfers, when you're doing your exercise, when you're playing your sports, are you developing symptoms during those periods of time? But they can go for a long time and have significant heart dysfunction without recognizing it. But you are all here today and you're going regularly for your screening appointments, so that's not going to happen here. But it used to. It really used to be not too long ago, 15 years ago or so, that boys were presenting in heart failure, severe end-stage heart failure, because no one was looking, and no one wanted to acknowledge the fact that, hey, the heart's a problem too. But we have a lot of prevention, a lot of interventions that are possible to really manage cardiomyopathy quite well. So symptoms: chest pain, palpitations, dizziness, fatigue, cough. Abdominal symptoms: loss of appetite, vomiting. Now again, these could all be symptoms of a flu, right? And that's what's most important. You could just, feel tired one day, right? Well, if you're, not sleeping well, you're going to be feeling tired, right? If they're very vague symptoms. So again, that's why to really know, it's like your body, right? You know what something's right or not. If you're tired because you did a lot of exertion the day before. But it's when things don't make sense to think about the heart. If you have that cold, that cough is not going away. It's been 2 weeks already. The flu should be done, but things still aren't feeling right. Those are ways to think of, when you should be thinking about the heart. So I don't want you leaving here or leaving any appointments thinking that every stomach ache and every cough and every I just felt my heartbeat is heart failure, because it's typically not, right? But it's to know the trends, to recognize the trends, to acknowledge changes from what's baseline. I think that's what's most important, okay? And these are, some, late signs, that we see with changes in physical exam of heart failure, with blood pressure, with really difficulty breathing and all that. Okay. So really, it's all about, our goals of heart failure management is really trying to balance the body's metabolic demands with what the heart can supply. So the energy that's needed for breathing and movement and eating and healing and fevers, right? How do we optimize the blood flow to the body? Well, we do that with medications, with fluid management, with nutrition, and different forms of mechanical support if needed, for a breathing standpoint, and more for a cardiac standpoint as well. So there's different components of heart failure therapies. key thing, treat modifiers of disease. I keep repeating the same things because these are, prevention, right, is worth it. What is that expression again, right? Well, prevention is worth a lot, right? Try to avoid infections. Treat abnormal heart rhythms, right? There's medication to treat that. Postoperative pain, to really be aware of what is the cardiac status in each situation. Medications that we have, I've mentioned some chronic medications that we use to try to prevent the progression of cardiomyopathy, ACE inhibitors, beta blockers, right? But when you're actually having symptoms and in a state of heart failure, that's when we start using more diuretics. That's when, if you're in a situation and you need to get increased blood flow to your body, if you're recovering from a surgery, if you've had a flu and your heart is weak and your body's not keeping up with the needs, that's when we have medications that you would use in the hospital. We call them inotropes, dopamine, milrinone. And then ventilatory support is quite important as well. And even, like BiPAP, SIP vents, all of these, interventions that we have now, the technology gets better and better, I'm amazed at, of how supporting respiratory status really does affect and prevent heart failure and treats heart failure. I hate the term heart failure, right? Isn't that an awful name? But that's, really describes, really the clinical syndrome that, that has been institutionalized, starting from all of adults who have coronary artery disease, that whole practice of medicine and all the research that goes into that, all of that is the same model that we use, for children, for boys, with DMD, and that there is a lot that's been learned about heart failure. Survival from heart failure is improving every decade more and more, and it's also the largest health problem in America. Right? So there is a lot of interest and funding and money into heart failure in general, which will benefit, trying to prevent the progression of cardiomyopathy and the development of heart failure in boys with DMD. So as I allude to that, we have more and more technology that's becoming available. Relatively easy things, pacemakers, defibrillators, if you're having any rhythm issues. But there's risk with every intervention that we do. And that's why it's very important, I think, to think proactively before you need any devices, before you get sick, of, well, what's most important to you? Are these devices the right thing for me, for my family, right? The risk of pacemakers and of defibrillators, they can treat rhythm abnormalities, but they also can deliver inappropriate shocks, right? We have an increasing array of ventricular assist devices, mechanical heart pumps. And this is really the key area of advancement in pediatric heart failure. That it used to be that any of the devices that are available, they were just made for huge big people. And there was nothing to be used in younger children or smaller teens and all that. They were for short term, and I'll show you some more images of it. But the field of ventricular assist devices and artificial hearts is really going to make a difference, particularly combined with, say, if we have other medications. Dr. Day and I were just talking, well, if we can get medications and things to maybe keep the breathing muscle stronger, keep the leg muscle stronger, even if it can't affect the heart as much, well, we're getting these different devices now and things that can work to affect the heart. And so kind of combining kind of the innovation from multiple fields, I think what's really key. And another way it's so important to bring the providers together so that people could be talking and trading ideas. Of course, mechanical circulatory support has a lot of risks with it as well. They are machines. You always need to be on anticoagulation, so your blood needs to be kept thin, and that there's no pulmonary support. So it's really pure cardiac support. And we'll talk a little bit more about them. There's heart transplant, which can give you a healthy heart without dystrophin and all that. However, to keep that heart alive, you need to be on lifelong immunosuppression medications. And every medication has an adverse side effect. So there's the downside of being immunosuppressed, so more at risk for infections. So say, for instance, if you don't have good pulmonary function, and if you're getting a lot of lung infections, and then you give medication to make your immune system weak, you have just not done the right thing for your patient, because now you have increased the risk for serious life-threatening infections. All right? But say if your pulmonary status is strong, and this is more commonly we'll see certainly with boys with different types of, more of like Becker's type phenotypes and all, but there's a lot of variability here, right? That if your lung strength, it's something that could be considered. But again, that not only is there no pulmonary support with a heart transplant, but the other way around, that if your lungs are weak, that's more stress on the heart. And a heart transplant, the new heart doesn't work as well if you're having a lot of work to do. And so the field of heart transplant for boys with DMD, it's a very case-by-case basis. It's all based on the individual. How is that individual affected? What is the risk benefits for that particular person? And these are the standard recommendations that have been issued now. So I mentioned these ventricular assist devices. Well, it used to be, as I said, we had these big, huge ones, like, this is Thoratec here. But they're coming down to a size. This is the size of a quarter, right? This is a hardware too. And this is the device we have. One guy, actually both of our long-term muscular dystrophy patients on support, they've been on for 4 years and 5 years respectively. I'll just go, Edgar allowed me to use his photo here, right, and everything. He has Becker's muscular dystrophy, but this is all a spectrum, and this is just an example of where we're going. That this is an implantable device. You wear batteries with you. You're on blood thinners. But he's outpatient, and he went to college and works, and you can live for many years on these ventricular assist devices. And these are the devices we have now. And again, this is where the whole field of heart failure is going, is in the development of smaller devices, better anticoagulation, of really long-term better cardiac support. Because still there are significant risks. Doesn't support the lungs. There's a high risk of stroke, from the risk of being anticoagulated, and at times of some infection. But again, this is a very different talk than I did earlier in my training 10 years ago. We didn't have these long-term devices to implant in medium-sized people. So again, a lot of optimism, a lot of hope. While we're working to kind of mitigate the effects of the dystrophin gene, we have ways, ways to help solve the problems that come up. So in summary of sort of the progression on the left, that I'd like to keep most people in the asymptomatic cardiomyopathy, and that is the majority. We use oral medications to delay progression. We treat disease modifiers. We monitor to detect early detection of progression. If you do start developing what we call compensated heart failure, that if the heart develops weakness, try to keep the body in balance, right? Where we treat symptoms, we manage fluid and salt, and then we try to prevent decompensations at times of increased stress. So let me pause there for a moment. Questions? I'm not going to go on until I get one question. Good question. So in different models of disease, well, let's take a step back. The heart muscle needs fuel to work on, right? I always start basic. The batteries of the heart muscle cells, mitochondria. And if you're missing any of these key vitamins or elements that keeps the mitochondria running, that keeps our heart muscle cells working, if you have a deficiency in any of these components, absolutely your heart muscle weakness will be worse. There are symptoms with carnitine deficiencies that you give carnitine back, the heart muscle works again. There are people with mitochondrial abnormalities where if you give these cocktails of different supplements too, then it makes a huge difference. But what we don't know is that if you're not deficient, does giving more make a difference? And so it's not currently, and we'll go through, there are some standardized recommendations from the cardiac societies. It's not part of the standard therapies. Now, I don't think they can hurt. The only way that I think taking supplements hurt is if they have side effects that are affecting your quality of life, right? And if there's any medication interactions with the medications that do have some proof of benefit of ACE inhibitors and beta blockers once cardiomyopathy has developed. So that's sort of kind of how I think about with the supplements at this point in time for this disease of DMD.
population of wearing heart rate monitors and all these exercise devices. Do you advocate for anything like that? And if you do or don't, why or what might you look for?
Yeah, great question. Exercise is fabulous for the heart, so yes. And what I would say with heart rate monitors is I think they're probably most useful to make sure that you're exercising as hard as you think you are. Because I think so often we just, I'll talk to myself, I start on the treadmill, I'm going for 2 minutes, this is awful, like I must be pushed to exhaustion. And my heart rate isn't, anywhere near sort of my target exercise goal. So I think they're good for helping you to see where you are in that range of exertion as an objective factor as opposed to sort of our warm-up stage. I think if you're having problems with heart arrhythmias, if you're having abnormal electrical activity of the heart and rhythm problems, you may want to keep the heart rate, say, less than 150 or less than 140. And so people with those types of problems or with severe systolic dysfunction, that's where those monitors come for, to sort of set an upper limit as well as to set a goal. So that's sort of how I think about it. But exercise is great for the heart. And the key thing is well, if it doesn't feel good, if you're feeling sick when you exercise, well, then it's time to stop, right? But in the sense of moderation, slow and steady, anything that's exercise is good for the heart in general. I'm sorry, I didn't hear the beginning of your question. Oh, excellent. Yes. All of that's good. The only type of exercise that's really not healthy for the heart is we call it isometric exercise. So heavy weightlifting. Anything you have to really exert yourself against. I say if you have to grunt, that's isometric, you're bearing down, that is not healthy exercise. Anything just against your own body weight is fine. And it's really, kind of avoiding any sort of, very of that isometric leg of pushing against something and you're not breathing well. Anything with good controlled breathing, anything getting the heart rate up, anything like that is good.
So how about swimming?
Fabulous form of exercise. It's great for the muscles, it's low impact. Right? It's a sport that many of our boys can carry on for a very long time, even if they're having muscle weakness, and you can absolutely get your heart rate up with it. I think swimming is one of the best exercises for people with neuromuscular disorders, because it gives you those cardiac aerobic effects as well as being able to do it.
Yeah. So I know most of the studies initially target the skeletal muscles, at least that's what I've heard. Are there any studies that are specifically targeted for the heart muscle? I heard some stem cell research was funded recently, I think in Cincinnati or Ohio. Can you talk more about that?
Yes, we can, and I'll go on. I have a research section in the talk here, so I'll address that in just a moment. Maybe I'll use that as a segue. So no other clinical questions. So I bring up these slides here just showing you that there is a lot of attention more and more that's being brought to proactive cardiac care for people with neuromuscular disorders, and particularly with Duchenne muscular dystrophy. The initial article at the top just about